It is now my pleasure to introduce the second talk, which will be given by Professor Annalisa Berzigotti, and she will speak about some new features and especially BFlow, an alternative vascular technique for the assessment of critical liver conditions. I take the occasion to remind to most of the participants that for those who are old enough, will remember that contrast agents for ultrasound were initially developed in the 90s to improve the Doppler signals. So we will listen now. The things have changed a lot, and maybe what was the initial thought is now completely abandoned because in this setting probably has become totally useless. Please, Annalisa.
Thank you very much, Fabio. And thank you very much to the organizer for inviting me being here today. It's a big pleasure. And I have to say that talking about this topic was extremely interesting to me because it allowed me to look at new features that were only partially discussed in the literature. And you will see that as compared to the talk of Professor Popescu, my talk will have much less strong data to support, but I hope I will show you with my experience that this new modality could be useful. And the learning objective is learn about alternative non-Doppler vascular techniques for liver disease, become familiar with the science of BFlow and their interpretation, and identify which cases of liver disease could be those interested in this new technology. And I will very shortly go through this point in my agenda. I will show you what are the standard techniques for the study of liver vessels, the condition in which assessment of liver vessels is important in the management, and where BFlow could have a role, and some example from our center. So I think you all well know as hepatologists or clinicians that the liver is a highly vascularized organ which has three different vascular systems, two inflows that are the portal vein and the hepatic artery, different among each other in the amount of blood rich in nutrients, which come more from the portal vein, or rich in oxygen, which is more from the arterial part, so hepatic artery, and just one outflow, that is the liver vein outflow. And the assessment of liver perfusion on each of these three vascular systems, and as well as the vessels in the focal liver lesions, is of extreme importance to diagnose or to follow up several conditions, either from, let's say, the standard chronic liver disease side or from the vascular liver diseases, purely vascular liver diseases side. And as experienced physician in ultrasound, I think you are all familiar with the standard techniques that we use that go from the standard bidimensional grayscale ultrasound to the Doppler-based techniques that can be color Doppler, spectral Doppler, or power Doppler, and to the, let's say, last important Doppler-based, initially, at least as Professor Piscaglia underlined, development of contrast enhanced ultrasound that can improve much Doppler techniques, but then evolve to something different and as an important standalone technique. So we have very many different techniques available, and many of them are excellent, and we use them day by day. But is there still some room of improvement? I believe there is, because I think you are also all aware of the limitation of Doppler techniques, which are mostly dependent on their dependency on the angle due to the Doppler equation. So we all know that if a vessel is basically 90 degrees to our visualization or the probe and our sampling position, we will have a lack of visualization of signal, or we can have different problems like artifacts, like the twinkling artifact if we are hitting a structure which has a very different reflectability in comparison to the remaining part. So we can have false positives in this part, or we can have false negative for flow. So we should solve this problem. And there is a new technology, which is the BFlow, that could help us, and we will focus our attention on it. So BFlow technology, or BFlow imaging, is a digital solution that is aimed at increasing the signal originating from the red blood cells and to suppress the signal from the remaining tissue using the so-called tissue-blood equalization. Basically, you are launching this ultrasound signal to both the red blood cells and the surrounding tissue, but then using a digital encoder, you are amplifying only the signal you get from the blood flow, but at the same time getting rid of the terrible increase of the signal you would get from also the surrounding part. So you are equalizing this, and this results in a image of the flow that will be then white, or let's say coded in color, and the remaining tissue that will be black. So it will be a bit the opposite that you are used to look in the standard B mode. So it's a way, let's say, to amplify the signal of blood without contrast, using just the standard B, let's say, signal you would get, amplifying it, and this will result in a sort of angiography without contrast with high spatial resolution. So how the images look like? This is an example. You can see here with the arrow a liver vein, and you can see the other vessel is the portal vein, and this is a normal situation where you can perfectly see both vessels using this technology without contrast. And here you can see that you have a very nice resolution, looking also, for instance, at the confluence or at the junction between the hepatic veins and the inferior vena cava, which is usually quite difficult to see. And if you go more in the periphery, in the liver, you can see very nicely even tiny vessels, like, for instance, the peripheral branches of the portal vein. And for those of you who are interested in the rare, let's say, vascular liver diseases or intrahepatic causes of portal hypertension, you might remember that the so-called portosinusoidal vascular disease or idiopathic portal hypertension is characterized by abnormal morphology of the peripheral branches of the portal vein, which I think you might be able to study in a very simple way with this technology. So when would I use it? I think anytime you would need an accurate vascular assessment of the liver, which is angle independent and requiring you to see the tiny details. For this, of course, vascular liver diseases, so thrombotic pathologies of the portal vein or liver veins would be, in my view, very suitable for this kind of imaging. And if you need to see very slow flow, like in the peripheral branches of the portal vein, either you use contrast or you would not be able to see it, but with the technology you might. If you have to address a cavernous transformation of the portal vein and identify, for instance, dominant collaterals, or understand better the morphology of these vessels without having a second line cross-sectional imaging, this could be a good technology. And for sure, for the assessment of the vena mesenterica superior, which by its anatomy is about 90 degrees of what you usually see, this is a nice technology. And as well, I will show you some example of use in patients receiving a transjugular intrahepatic PORTO-SYSTEMIC shunt. So let's start from some cases of suspected thrombosis. So we had a few months ago a patient that was in our ward for a cholangitis, and there was a bit of increase of liver enzymes, and the question was whether he could have also some thrombotic problem. We could rule out a major portal vein thrombosis, but if you see, what is interesting to see with this technology is that you can see in the peripheral branch of the left portal vein a lack of flow, which is characteristic of portal vein thrombosis. You can also observe that the signal of the artery coming around the portal vein is increased. So this was a peripheral thrombosis, which I think we would have missed without this technique, and that was confirmed on CT scan. This is a case of a patient with known chronic extrahepatic portal vein obstruction, so-called portal vein thrombosis in a non-cirrhotic liver, you can see that the liver is remodeled, and you can see lack of standard flow and substitution with a cavernous transformation. But if I have to say something more on this power Doppler imaging, I cannot say much more. And moreover, I cannot study very well where the collaterals are being are directing into the flow. And you can see that using the B-mode imaging technology, you have a fantastic depiction of the cavernous transformation vessels, which clearly are directing into, in this case, through the in the direction of the gallbladder, and which you can really very nicely, much better see with B-flow imaging into the gallbladder wall, which is an aspect that you could, of course, suspect on the standard B mode. You could maybe address it also with color Doppler, but I think that the detail you get with this technique is excellent. The depiction of the cavernous transformation is excellent. You can also guess that there is a dominant vessel. In the wall of the portal vein, you can see the tiny vessels. And if you increase the frequency of your probe, you are able also to identify much better the artery and differentiate the two of them. And I think this could be a very nice application also in patients that have to be studied after liver transplantation, in which you need to know whether the artery is open or not, and sometimes it's not so trivial, and you need contrast enhanced ultrasound. I have no cases to show you today, but I had some cases in which I could use this technology, and they can support it because it was sufficient and confirmed then by by contrast enhanced ultrasound to study the artery. This was a difficult case we had. This was a 30 years old woman presented with abdominal pain and ascites. We did a CT scan in the patient, and we could see that the liver was already a bit dysmorphic, but there was also an acute thrombosis of the portal vein associated with a complete thrombosis of the superior mesenteric vein. And since we know that in this case it's associated with ascites with initial signs of intestinal ischemia, there is a high risk of inefficacy of standard anticoagulation after a few days of anticoagulation, and since the symptoms did not disappear, we decided to go for an invasive recanalization of the mesenteric vein through a TIPS approach, given that the patient had also signs of chronic disease. And you can see that this is the access through a transjugular route. We could see angiographically that the thrombosis was very large. We put a TIPS in, we recanalized by mechanical thrombolysis and then thrombolysis the vessel. And what was very nice to me was on the following days, being able to follow up this patient via ultrasound, since we could see through this new technology the vena mesenterica superior. And I can tell you that color Doppler was not really helpful in this situation, even after optimization, while you can see that we could prove via B-mode imaging that the vena mesenterica was open after this recanalization procedure and remained open in the follow-up, and we could confirm it with CT, but we are following up this patient non-invasively. So TIPS, I think you are all familiar, but just to remember what TIPS is a shunt, so a stent that is put through the liver by puncturing from a liver vein to the main right portal vein that is aiming at reducing portal pressure, and this is a life-saving procedure in patients with very severe complication of liver disease. And this is an example of a patient who was admitted to our ward unfortunately, after a first episode of variceal bleeding in the December of the year before, so of the 2020, not 2021, sorry, there is an error. The patient was listed already for transplantation at our center because of a very severe PBC cirrhosis. And at the time of the first variceal bleeding, she was not treated with early TIPS, which she should have been, in my view, because she was at another center. She came to us, and in February 2021 had a second episode of bleeding. She was very sick, and we could identify on CT a partial portal vein thrombosis, as you see indicated by the arrow, and the decision was immediately to try to put a rescue tips in to try to keep the patient on the safe side for allowing a transplantation later on. And these are the images which I took during the tips positioning. We always, in the angiography room, check again the patency of the portal vein with imaging, and I could use this new technology, and you can see how well you can see the thrombus in the portal vein, and how well you can identify the liver vein and the portal vein on the same axis, allowing you then to guide the puncture to the portal vein from the liver vein in a very easy way. And you can see from these arrows on the left, this is the needle that we put, of course, from the liver vein to the portal vein to access the portal vein and put the tips in. On the right side, you see what was the angiography image and the measurement of pressure in this patient, which of course was high as expected due to this severe portal hypertension. You can also see in the portal vein the aspect of the thrombus, that is this lack of complete replenishment. And so we could guide the puncture much better. Furthermore, you can really sort of follow in real time what is happening also with the different material you put in. You see on the left side, this is the stent, which was already put in, but not yet dilated. And you can also see it with the B-flow into the portal vein, so very nicely. And this is the end final result. You can see that after mechanical thrombolysis, most of the thrombus was removed, the tips was open, and the portal pressure gradient after tips was decreased to a safe 9 millimeters of mercury threshold. So, and the patient stopped bleeding, fortunately. After positioning of tips, I think this technique could have a role. So you see here, for instance, an example of a patient who had the tips put in another center. It is a bit anatomically a bit strange, the tips, but still we were following up him with the standard, which is a color and spectral Doppler. The tips was open. The portal vein velocity was 28 centimeters per second, so not particularly high, but not even very, very low. Velocity intra-tips was not very high. Usually it's above 1 meters per second, but it was not even very, very slow. And there was a drop of ascites perihepatically and nothing else. And the patient had a very normal liver function. So I think in these cases, you can be uncertain of whether this is a tips dysfunction, that would be a stenosis of the tips that can happen in the middle long term, or if it is an aspect that is not related to a tips dysfunction. So I hope the video will work. We used the new technology, and you should focus on the right part, not now, in a moment. Let's do it again. The right part below, you can see that it seems to be something not completely filling the tips. And if you look with more detail and more time, we really strongly suspected that this lack of flow that you see with B-flow was indeed a stenosis of the tips. And so we decided, based on this technique and of the overall assessment of the patient, to go to an invasive assessment, which is the gold standard to rule out or rule in a tips dysfunction. And we could see that indeed there was a tips dysfunction, so a reduction in the lumen, but very tiny, however sufficient to increase the portal pressure gradient. What we did is dilating the tips with a simple balloon, and after revision, so after dilatation, pressure was again normal. Just to finish, to give you this overview, I think there could be a role also for the study of focal liver lesions, at least in non-cirrhotic livers. This is a patient that we could observe with this hyperechogenic lesion, which has an aspect that already on power Doppler suggests very likely a focal nodular hyperplasia, because you see a central vessel, and on spectral Doppler, it seems to have an arterial flow. But I think with this additional technology, you can be pretty sure. So you see that there is a central artery, and in the other images, we could see that it was really the typical aspect you expect in FNH. So this is another patient who was, again, in a non-cirrhotic liver. He had this rounded lesion that looked totally benign, and as a first aspect, it was slightly hyperechogenic, But you see that looking with this technology, while on color Doppler and power Doppler and spectral Doppler, we could not get any signal at all. Here there was flow. The flow was in the periphery of the lesion, and you can see a central part that has no vascularization, which is probably the central scar of the hemangioma. Anyhow, since we could not be totally sure, and the images were not, let's say, on the standard mode, not typical, we decided to go for a magnetic resonance that confirmed that this was indeed an hemangioma. So I hope that with these examples, I could prove that this technology has an excellent spatial resolution and can allow visualization of vessels with very low flow or slow flow. I think it complements the standard ultrasound Doppler techniques to assess cases of suspected vascular liver disease and to improve the follow-up of these difficult cases. And I think it could be seen as a bridge between the Doppler-based technique that remain fundamental in our clinical practice and shifting to our next step, that is using contrast-enhanced ultrasound to prove or rule out thrombosis, for instance, in these cases, or perfusion. And with this, I would like to thank you for your attention, and I would be very pleased to take your questions. Thank you very much.
Thank you very much, Annalisa.